ഇത് റെക്കോർഡിംഗ് നടക്കുന്നുണ്ട്. ഞാനിപ്പോ മ്യൂട്ട് ആവാത്തത് കൊണ്ട്, ഞാൻ മ്യൂട്ടഡ് ആയതുകൊണ്ടാണ് വരാം. റെക്കോർഡിംഗ് കാണിച്ചു. കഴിച്ചിട്ട് വന്നാലോ? റെക്കോർഡിംഗ് remembering the presentation, no, ma'am? Okay, okay. Okay. I'm calling that. Hello. Hello.
Case discussion. నాది గాల్లో అయిపోయింది నిన్న. లక్కీగా ఆల్రెడీ ప్రిపేర్ చేసింది ఉంది.
I think we can start.
Hello.
Maria, start.
Okay. I hope you can hear it. So good afternoon, everyone. We can start today's presentation. So I'm Dr. Maria Joseph, and I'm DRNB Neonatology Fellow. So we will be discussing I will be discussing two cases that we had come across during the last 1.5 years, which was quite interesting. And there were certain similarities among them, and both for academic purpose as well as a clinician, we felt it would be very relevant to have this case discussion. So, it's encephalopathy beyond HIE. So 2 cases we'll be discussing, and from now on we'll be labeling them as neonate 1 and neonate 2. So neonate 1, who had a normal antenatal course and born to a 3rd-degree consanguineous couple, delivered by normal vaginal delivery at 38 weeks. It was a term delivery, a male baby, and baby required just stimulation and not beyond that, with a normal birth weight. But then it was an AGA term baby with 3.2 kg. Postnatally, post-delivery, baby was initiated on direct breastfeeds within 1 hour, however, had poor suck and decreased activity, and also noted to have tonic posturing, which began at 5 hours of life with of eyes towards the right side, and multiple episodes, 8 to 10 episodes happened on the same day. The baby was actually born, it was an outborn baby. Baby was born in Andhra and loaded with anti-epileptic drugs, levetiracetam and phenobarbital. And in view of the refractory seizures and the persistent encephalopathy, was referred to KKCTH. The cause of KKCTH, when the baby came here to us, the baby was cyanosed with saturation around 85% in room air, and baby had respiratory distress and stridor, in view of which we started on HFNZ, and hemodynamically baby was stable. And regarding CNS, baby was pretty encephalopathic, and baby had very poor activity, and there was hypertonia on day 3 of life itself, and the Thompson score was 11, which was suggestive of moderate encephalopathy. And what was most striking in the baby was baby had multiple episodes of seizures. There were tonic posturing with staring of eyes, and also cycling movements and even stridor, which was persisting throughout. And for the same, we had actually we had to load a lot of anti-epileptic drugs, and the baby was on 4 anti-epileptic drugs for the same. So in view of the persistent seizures, persistent encephalopathy, with the other systems not much affected. These are the series of things that we had done for the baby. Just we are presenting very crisply so that we can present and compare both the cases together. So we did a continuous AEG monitoring, the CFM monitoring, and we noticed short-lasting elevation of both the upper and the lower borders. The baseline voltage was elevated with intermittent spikes with absent sleep-wake cycling. The conventional EEG was done twice, and both of them were done twice, showed normal background activity with birth suppression. So initially, actually, this EEG was reported as normal, but in view of the persistent seizures and this abnormal CFM, we actually did another conventional EEG, which also showed a birth suppression pattern. We went ahead with MRI brain once the baby was stable, and it was actually reported as suggestive of moderate HIE. There were hyperintensities in the globus pallidus. However, it was not very typical of HIE. And because the baby did not actually have a proper history of resuscitation, and because MRI was not very typical of HIE, this refractory seizures, we just couldn't attribute it to the HIE. So in view of which, we went ahead with metabolic workup, which was normal. And the baby was started on 4 anti-epileptic drugs, including the, in addition to the levipil and phenytoin, We added on lacosamide and carbamazepine and even pyridoxine after neurologic consultation. And because we were not very convinced regarding the HIE part and we could not get any metabolic clue, we went ahead with the clinical exam. So this was MRI done, and the only positive feature thing was that there was hyperintensities in the globus pallidus. And this is the baby's burst suppression, which was recorded in the conventional EEG. Even that was also like not very convincing for our neurologist, but baby had in between burst suppression pattern. And other things which I would like to mention, which was peculiar to this baby was the baby had multiple pituitary hormone deficiency. So the baby actually had central hypothyroidism with very low TSH and T4. And in view of the same, we went ahead with evaluation of the other pituitary hormones. So we found to have, the baby was found to have low serum cortisol levels. And hello. In view of which the baby was started on hydrocortisone as per our pediatric endocrinologist opinion. And the baby is actually still on follow-up. ACTH levels are normal for the baby. And now the rest of the pituitary hormones, the rest of the profile is also normal. So that is about neonate 1. So neonate 1 was actually
राजस्थान और किसी का था राजस्थान जीत गया.
Excuse me. I request you all to kindly mute yourself, please.
क्या खाना है वो बताओ तुम. सैंडविच खाएगा?
So we had a neonate
तो फिर
who
कुछ भी
was
क्यों
a term AGA baby who had refractory seizures and was no proper history of any resuscitation or any post-natal hypoxia. So now we come to another neonate, that is neonate 2. The neonate is a term
यहाँ पे तो पूछता नहीं है क्या हम लोग बैठ के यहाँ पे चला जाएगा.
non-consanguineous couple, female, again cried immediately after birth, required no resuscitation. It was a term SGA baby with birth weight of 2.42 kg. The baby immediately, actually in the post.
Maria, please hold on. There is a lot of background noise.
Yes.
I think someone in KEM HRC team. KEM HRC team, please. Can you hear us? Please mute yourself.
So the host can mute any participant. Maybe she can do that.
Yes.
Maria, you all participants.
सैंडविच खाना नहीं है तुमको. बुलाना पड़ेगा उसको तो पहले और कुछ सोच के रखो.
KEM HRC team, are you there? You mute all participants. Go to the options and mute all participants.
So where is it?
They don't seem to listen also. They've just put it on and they're not listening.
So she can mute him individually by going into
Initially, I knew once I started to share the screen, I am not able to find that option anymore. Where is it? Mute all option and participants, I think. Yes, I got. Okay.
Okay, start now. Neonate 2, you start.
So, okay. So neonate 2, am I audible? Okay. So now coming to the neonate 2. So again, this baby was also a term baby, 37-weeker baby, born to a non-consanguineous couple. It was a female baby. The baby also did not require any resuscitation post-birth, and the birth weight was 2.42 kg. The baby had respiratory distress and required oxygen for 17 hours. And again, this baby also presented with seizures, which began in the first day itself, like the other baby, 18 hours of life, with a rolling of eyes with clonic movements of all limbs. Again, required multiple anti-epileptic drugs for the same. And the baby was encephalopathic with poor activity and depressed sensorium, and view of which the baby was actually mechanically ventilated. Okay, so again, we went ahead with our the EEG. So the conventional EEG initially was reported as normal for this baby, but the repeated conventional EEG was just a birth suppression pattern. MRI brain was actually normal, completely normal. So again, it was a dilemma for us because baby had refractory seizures with a very normal MRI. We went ahead with metabolic workup, which was normal. And we actually did an exchange transfusion in view of refractory seizures, and baby was very sick. In view of the same, we actually gave a trial of exchange transfusion also. And we had to add pyridoxine, and the baby was on 4 anti-epileptic drugs actually on the maximum dose. In between, baby had a little complicated course with E-cloacae meningitis, for which baby also received meropenem and vancomycin. So again, because baby had refractory seizures and it was non-consanguineous marriage without any clue in the MRI or the metabolic workup, we had to go ahead with the clinical exome. So these two cases, we had, this is the birth suppression pattern. I think it's not very clear, but this is the birth suppression pattern we got in the conventional EEG of the second baby. So both these babies were very confusing to us, because both of them had difficult to control seizures with no positive history of resuscitation and no definite features in MRI, however, with some abnormality in the EEG. So this is our neonate 1. So this baby actually had different types of seizures. So these are the cyclical movements, the cycling movements we notice with the baby. The baby also had stridor as well as tonic posturing. And these seizures were like continuous for both the babies, and it was very hard to control them. Okay, so there were certain similarities and differences among both. So the similarities were the age of presentation. Both the babies presented within the first day. There were no sentinel events, and the seizure started around 5 to 18 hours in one baby, like both within first 24 hours of life. And encephalopathy was quite severe, and both had a common pattern EEG. Both were suggestive of birth suppression pattern. The differences was like the first baby, the neonate 1, had a 3rd degree consanguinity, while the second baby, there was no history of consanguinity. Semiology was a little different, and difficulty in controlling seizures. So our first neonate is actually a baby who came to us in 2019, towards the end of 2019. So although we had a difficult time in the hospital, this baby actually, that is a neonate 2. The baby actually is presently 1.5 year old, and now the seizures are well controlled. So initially, although we had a difficult time in hospital, after that, seizures were reasonably controlled. Presently, baby is on 2 anti-epileptic drugs. However, the neonate 1, multiple admissions were required, and the baby actually, the post-neonatal period also was with us even in the last month. So that was a little more difficult to control seizures. And imaging again, the neonate 1 had features of HIE with the hyperintensities in the globus pallidus. However, in neonate 2, there was completely normal MRI. And the other thing was we had noted some association wherein multiple pituitary hormone deficiencies were seen. So that again was a difference between both. However, we felt there was some common some similarities between the cases. So the differential diagnosis we had in the back of our mind were, one is HIE. However, there was no definite history of perinatal asphyxia for both the babies except for some prolonged stimulation for the first baby. Second was IEM. However, baby had seizures on day 1. It was not related to feeds. And after all, the basic IEM evaluation was essentially normal. Then congenital brain malformations. However, the MRI has not shown anything suggestive of the same. And we had the possibility of the remote epileptic encephalopathy in the back of our mind. So we were actually awaiting the clinical exome. And then the clinical exome report came. For neonate 1, it was suggestive of KZN-Q2 mutation. The neonate 1 actually had KZN-Q2 mutation, which was actually an autosomal dominant one. And it's called it's the disease is known as developmental and epileptic encephalopathy type 7. So that could explain the seizures of the baby. And there was another mutation noted for the baby, that is a DNM1 mutation. So this is the clinical exome report of baby 1. And the baby 2 also had KZN-Q2 mutation. Again, so we felt one of the neonates came to us 1.5 years back, and we actually had that in the back of our mind where we had a KZN-Q2 mutation. So when this baby came to us, although a little different, the baby was behaving like the baby had other associations, we still had that in the back of our mind. So both of them came out to be a KZN-Q2 mutation. So we had a few things which could not be explained by the same, like one, like the pituitary hormone deficiency, we could not find out the cause. It could be an association with a genetic mutation, that's what we thought, but an extensive literature search for both the mutations associated did not reveal any actually. KZN-Q1 mutation, there seems to be some association with pituitary hormone deficiency. However, Q2, there have been no reported cases yet. Then another DD from our part was, as per our pediatric endocrinologist, he opined that it could be due to a seizure or anti-epileptic drug-induced pituitary suppression. And then other thing is, there could still be other associated gene mutations. So we have sent actually clinical exome sequencing, which could have been missed. So that is another possibility. So I will just go in short about KZN-Q2 mutation, because we have seen 2 cases. We would like to I'll quickly go through it. So KZN-Q2 is a gene, as the name shows, KCN. It refers to a gene for potassium channel, which is present within the brain, located on the long arm of chromosome 20, position 13.3. It plays a key role in the cell's ability to generate and transmit electric signals. And this mutation shows a very varied spectrum of disease, from benign seizures in infancy to epileptic encephalopathy. So basically, there are 2 main spectra. You can classify it into 2, where it can be benign familial neonatal epilepsy. As the name suggests, the baby can have seizures, a wide spectrum of seizures, from tonic or apneic episodes to focal clonic activity or even associated autonomic changes. And it can be confined to one body part and migrate to other body regions or generalize. However, usually these seizures are brief, lasting for few minutes. And onset is usually from day 2 to 8. However, our baby had on the day 1 itself. And the major thing in this BFNE, or the benign familial neonatal epilepsy, is that it disappears by 1 year. So, and rarely evolve into status. About 10 to 15% of individuals develop epileptic seizures later in life, and the EEG and MRI is usually normal. So for our baby, that is our neonate 1, neonate 2, the baby, we assume the baby could be actually BFNE, because baby is now 1.5 years, seizures are well settled. The EEG had shown burst suppression. However, the MRI was normal. The baby could be in the spectrum. So the case in Q2 with the other end of the spectrum is the neonatal epileptic encephalopathy, where again multiple seizures occur daily, and usually it is tonic seizures with associated focal motor and autonomic features within the first week of life, like the other spectrum. And the seizures generally cease between 9 months to 4 years. However, these babies have moderate to severe developmental impairment, and these seizures can last up to 4 to 6 years. Unlike the benign case where usually by 1 year the seizures settle. EEG shows burst suppression pattern or multifocal epileptic activity, and MRI may show basal ganglia and thalamic hyperintensities. So treatment, anti-epileptic drug of choice is usually sodium channel blocker, phenytoin, or carbamazepine. So that these are the first line drugs can be used. And in such a case where you have a mutation, the genetic counseling part is important because it's an autosomal dominant condition. So definitely it could be a de novo mutation also. So, however, you have to get the parents also genetically tested. So prognosis in BFNE, the seizures are controlled with no cognitive impairment and with a normal IQ. However, with any or the epileptic encephalopathy type 7, seizures may persist. So usually it gets controlled 4 to 6 years, but seizures may persist to adolescence, and the infants or the children may have moderate cognitive impairment. So this is our 1.5-year-old baby. Presently, seizures are controlled and developmentally baby is normal. Thank you.
So thank you, Dr. Maria, for that presentation. So this case series of 2 neonates we presented basically to sensitize the audience and students here that there are so many conditions which can present like HIE, but I mean we need to be aware that so many causes are there other than HIE which could account for encephalopathy. So in most of the time, like especially in an outbound unit like ours, wherein we do not get the details of resuscitation, we do not have any access to the resuscitation which was done to the baby. We have to rely basically on sketchy summary which is provided to us, as well as we have to fit in with the clinical presentation of the seizures and encephalopathy to identify and the presence or absence of other multi-organ dysfunction to arrive at a diagnosis, whether of course MRI comes in handy in diagnosis. So when certain things are typically do not fit into such typical pattern of HIE, then we go on and investigate further to identify the exact etiology. So so for exam students point of view, I would like to ask Dr. Maria, so what are all the things you would suggest that encephalopathy could be due to HIE? What are all the features in history as well as in the clinical presentation and postnatal examination of the baby would help you to tell that encephalopathy could have been due to HIE?
Yes. So, sir, so basically, whenever a baby comes to us, one thing, the most important thing is history. So we can actually start from the antenatal period itself. So antenatally, we can ask if there were any Doppler changes associated. So that could be a perinatal, prolonged perinatal hypoxia could have happened in the antenatal period itself. Then postnatally, you have to have a history regarding the postnatal resuscitation. So whether baby required any resuscitation, if required, what was the extent to which the resuscitation had to be done for the baby. And after that, we have to ask regarding the sensorium, the encephalopathy, whether the baby was started on feeds, whether baby was sucking properly, whether there was any abnormal like inability to suck or inability to sustain suck regarding feeding pattern, seizures, and that too regarding the occurrence of seizures. When was the first episode of seizure that occurred? Regarding the tone of the baby, as well as the cry pattern, where any abnormality regarding like any shrill cry or abnormal cry noted, and also the semiology and difficulty in controlling seizures. So sentinel event is important, encephalopathy is important, seizures and tone. And you can ask, if possible, for the staging, if done, if it is an outbound unit, what was the stage of Sarnath and Sarnath, if it is possible, we can ask regarding that cause also, if the baby is not born in our unit, regarding history.
So anybody else would want to contribute anything more?
And also relation to feeds, whether the seizures actually started after feeds or even before seizure feeds had been started, first day itself.
So any other point anybody wants to add? So as Maria pointed out, the presence of sentinel event is very important. So what are the sentinel events we would ask for? Presence of fetal distress, cord prolapse, any other cord accident, antepartum hemorrhage, placenta previa, abruption, okay, or any uterine rupture. So these are all the things, presence of a sentinel event. Okay, so when such sentinel event is there and then history of resuscitation is there, then most likely, I mean, you can say that encephalopathy could have been due to HIE. So history of resuscitation, if history of resuscitation is there, we should also know, find out what extent of resuscitation was given. PPV was given for how many minutes? Was there a need for chest compression? Was there any, was there a need for adrenaline? So if at all we could get the details about when baby started breathing. So all these things are important. In an inborn unit, so or if you go and attend a resuscitation, please make sure that at least in such babies who require long resuscitation, to do a cord blood gas, which will give lot of information about the asphyxia or perinatal depression which happened in the baby. Then after the baby is shifted to your NICU and baby is admitted in NICU, you should look at the clinical features of other organ dysfunctions, and babies can have myocardial dysfunction, babies can have oliguria, they may start developing seizures sooner or later. Okay, so if the baby was not born in your unit and it is from outborn unit, and even though the parents deny that there was any resuscitation done to the baby, we can very well ask whether baby was able to feed well on breast from day one, whether the baby was able to suck or baby was lethargic. So these are all the things which tell us that baby was apparently not normal soon after birth. Okay. So on the contrary, so if it was not due to HIE, these babies would have been apparently well for some time before showing deterioration. So these two babies were kind of relatively, apparently well for some time before started showing features of seizures. Okay. So these are all the things which will help us to identify whether the seizures are due to HIE or not. So I again would like to ask Dr. Maria. So how will you interpret the cord gas findings? Like how you will use cord gas to confirm confirm encephalopathy is due to asphyxia or not?
Okay. So ideally, the best parameter would be the cord blood gas, and if not available, at least the gas done within 1 hour of birth. So in cord blood gas, you have to look at the pH. So the pH, so the normal pH is more than 7.2 in a cord blood gas, but any pH less than 7. Hello, am I audible?
Yes, yes.
Yes. So you have to look for the pH and the base excess, and so any pH less than 7.2 is abnormal, and base excess more than, hello.
Mute. Dr. Subodh, please mute yourself. Dr. Subodh. Yeah, go ahead.
Yes.
Maria.
Yes. So cord blood gas, you have to look at the pH, the base excess, and also usually you may get a mixed respiratory with metabolic acidosis also, which can also indicate whether it is an acute event or acute on chronic event. So any pH less than 7.2 suggests HIE, and pH less than 7 suggests severe HIE. And even therapeutic hypothermia is based on the criteria based on the cord ABG.
Thank you for that clarification. So blood gas is very useful asset in differentiating whether attributing the cause of encephalopathy to HIE. So if cord gas was absolutely normal, then the encephalopathy is due to some other cause. It can be due to these epileptic encephalopathies or brain malformations or IEM. So taking cord gas in babies definitely will help us identify what could be the cause for encephalopathy. Okay. So when you will strongly suspect IEM could be a cause for encephalopathy. Anyone else want to answer? So if no volunteer, then Maria only will answer. Go. Yes.
Yes, sir. So what is the cord? Can you repeat once more? I have not.
When you will suspect IEM as cause for encephalopathy based on history and findings.
Okay. So so first of all, we have to look for any there is no sentinel event. The baby was apparently usually a term baby who is appropriate for gestational age, and there may be a consanguinity. So consanguinity also history is very important. Who is apparently normal and did not have any encephalopathy or seizures in the first few days of life. However, after the baby who develops new onset seizures or progressive encephalopathy, usually towards the end of the first week. So that is the time when the baby is on full feeds, and which is usually refractory, with sometimes with consanguinity, positive consanguineous history, or previous siblings who had similar history, who had seizures or encephalopathy in the neonatal period, and also difficult to treat seizures with other organ involvement. All these are points which suggest IEM. And there is no central event suggestive of HIE, and the MRA and the EEG may be usually normal.
So when a baby presents with a history of deterioration after initial well-being, obviously our diagnosis would be whether sepsis or meningitis or IEM. Okay, so these are all the two common things we would always think when a baby after a relative well-being presents with some clinical deterioration and features of encephalopathy. So when IEM is a strong possibility, obviously in our country we should think sepsis as the first possibility. So sepsis shock is that's the first possibility in any baby presenting after a relatively normal well-being. But once you have ruled out sepsis, then you have to suspect IEM if there are certain abnormalities, like baby is profoundly encephalopathic with abnormalities in blood gases also. So most of these IEM which would present with encephalopathy will have severe metabolic acidosis at presentation. So some of the hyperammonemias, okay, they can urea cycle disorders can present with initially metabolic, respiratory alkalosis also before progressing to metabolic acidosis. There are some metabolic encephalopathies wherein there will not be any blood gas abnormalities. Can you name a few of them, Dr. Maria? Hello.
Urea cycle disorders.
Urea cycle disorders, now only I told there may be respiratory alkalosis to start with, and then they will progress to metabolic acidosis. Yeah, somebody has.
Hyperglycemia.
Yes, very good, very good. NKH will have normal gas, and then other metabolic conditions which can present mimic HIE can have normal
cofactor deficiency, sulfite oxidase deficiency.
Yeah, so molybdenum cofactor, sulfite oxidase deficiency, all these things will have normal gas. Okay, so presence of normal gas does not rule out IEM. So there are some questions in chat box. So you have done exchange transfusion for refractory seizure in a baby, whether it is indicated, whether there is any evidence for that. Obviously, there is no evidence for that. So when you think of metabolic cause, because this case happened 2 years back, and at that time we weren't strongly thinking of this KCNQ2 as a possibility. So what we considered was it could be one of the metabolic causes wherein blood gas abnormalities are not there. So initial TMS, GCMS were normal. So we thought this could be probably NKH, some metabolic abnormality, which wherein the blood gases are normal, and we are not able to confirm soon because it's no CSF glycine levels and all these things takes time to you take 4-5 days to get the report. So in the meantime, we wanted to somehow clinically control the seizures. We were already on 4 drugs and we could not control the seizures. And then we took the decision that, okay, either peritoneal dialysis or exchange transfusion we should do to just, remove these abnormal metabolites, whatever it may be. And then we went ahead and did. Okay. So routinely, I mean, obviously it is not recommended for management of refractory seizures. So unless, you strongly suspect some metabolic abnormality wherein you really think that it may help baby, you can, there is a role that in that case, there is a role for exchange transfusion in severe sepsis also, right? So it has to be individualized to a patient and it is not routinely recommended. So next question in the chat box is, any other question? I'm not able to find those questions. Okay, if there are no questions in chat box, then I will continue the discussion. So, we discussed about the features which will tell us about, IEM, when IEM could be a possibility. So we should also know that there are IEMs which can present without abnormalities also. Okay. So whenever a baby with seizure presents, as a neonatologist, as PGs, you should also know, what are the common causes of seizure on day 1 of life, day 2 of life, day 3 of life, like that. Okay. So what is the commonest cause of seizure in a newborn? What is the commonest cause of seizure in a newborn? Anybody?
HIE.
Who said HIE? Meena. Yeah, HIE is the right answer, right? Okay. So HIE is the commonest cause of seizure. It is not hypoglycemia or hypocalcemia, right? So hypoxic ischemic encephalopathy is the commonest cause of neonatal seizures. Okay. It accounts for more than 1/3 of neonatal seizures. There are other metabolic causes come down the list only. Then the next, other than this transient metabolic disorder, other common cause could be sepsis with meningitis. Okay. So in order of priority, these are the causes. So other rarer things could be some brain malformations, intracranial hemorrhages, all those things. Okay. So in a day 1 seizure, what are all the causes you will think? The baby presents with day 1 seizures. Any volunteer?
First will be HIE itself,
Yes.
and the other causes we can also look for hypoglycemia, and on day 1 if the baby is SGA, IUGR,
Yes. Yes.
and IVH related seizures can
Yes.
be there.
Yes. Okay. Yes. Then anything else?
And pyridoxine dependent seizures.
Very good. Very good. One more, which may not be so common, but if mother is kind of addicted to some drugs, then the drug withdrawal effect can cause seizure.
Opioid withdrawal.
Yeah, opioid withdrawal or local anesthetic injection into scalp, lignocaine. Okay. So that can cause seizure on day one. So these are all the causes for seizures on day one, or any traumatic delivery which is causing intracranial bleed. Okay. Not the IVH of prematurity, but traumatic delivery with intracranial bleed. So these are all the things can present with seizures on day one of life. Day two. Day two, what is common?
Day two, again, HIE can be a cause, but
Yes,
other common
yes.
cause would be hypocalcemia.
Very good. So on day two, hypocalcemia may be more common than hypoglycemia, but still hypoglycemia is a possibility. But hypocalcemia is more common in day two. HIE still can be the cause. Okay. So all other causes you have enlisted can present on day two also. Okay. Day three.
SAH, hypocalcemia.
Day three, again hypocalcemia, but sepsis, meningitis also becomes a predominant cause from day three onwards. Okay. Right?
Yes, sir.
Okay, fine. So I would like to ask one of you, like, how do you classify seizure in a newborn? Any volunteer? Whether classification of seizure will help you identify the cause and prognosticate. Anyone? So you can unmute and answer. Yes, somebody has typed Arun Kumar.
So it can be it can classify based on the seizure semiology, like
Yeah.
seizure semiology with subtle seizures, or it can be clonic seizures or myoclonic seizures and atonic seizures.
Atonic in a newborn.
So less common, sir.
So the commonest types include subtle, okay, then clonic, tonic, and myoclonic, right? Clonic can be focal or multifocal. So these are all this is what the common classification which is used. So now recently some ILAE classification of neonatal seizures has come, which is more extensive. It includes some other subtypes as well. So you are expected to know ILAE classification also. So can you tell me what is the cause for clonic seizures? What conditions will cause clonic seizures, focal or multifocal? Multifocal clonic, what could be the common causes, and the unifocal clonic? Yes.
So unifocal clonic can be due
Multifocal
to perinatal stroke.
Yeah.
and also hypocalcemia will lead to multifocal clonic seizures.
Very good. So multifocal clonic is almost always due to these transient metabolic problems, hypoglycemia as well as hypocalcemia can cause. Okay. Of course, HIE seizures also can be multifocal clonic. Okay. But most commonly, these transient metabolic abnormalities will cause multifocal clonic. Focal clonic, on the other hand, in a term baby or near term baby, you should always suspect a perinatal stroke. Okay, it is always due to an thromboembolic event. Okay, invariably, I mean, it's a coincidence. Last month we had 3 babies who presented with seizures on the same day, and all 3 of them had a stroke. Okay, so it is so common. Okay, you will be surprised if you, unless you do a neuroimaging, you will not be able to identify. So history is very important in neonatal seizures. Treating them symptomatic, giving them symptomatic treatment and controlling seizure does not, it does not end with that. Okay, so you really start treating the baby after the seizures have been controlled only. So the task is in identifying what is the cause and go to the root of it and identify and treat it. Okay, fine. So what are the causes for tonic seizures? Tonic seizures, Whether can it happen in a term baby as well as preterm baby? If so, what is the cause in preterm? What is the cause in term baby?
In preterm babies because of PVL.
PVL, no. PVL
Or
usually does not cause
hypoglycemia.
seizures. In preterm,
Hypoglycemia may cause.
tonic seizures are more common in grade 3, grade 4 IVH. Okay. In a preterm baby. In a term baby, it can be because of encephalopathy due to these IEMs. Okay. Inborn errors of metabolism or some these brain malformations, severe brain malformation, epileptic encephalopathies can cause tonic seizures. Okay.
Ohtahara syndrome.
Yes. So myoclonic seizures again will be seen in epileptic encephalopathies or NKH. Okay, like that. So based on the seizure semiology also, you can identify what could be the likely cause for the seizure. Okay, it may not be always true, but at least in focal clonic seizures, you can very much say that it is due to stroke. Okay, so describing the seizure in a newborn is important. So don't just present that baby presented with 3 episodes of seizures. So you have to ask history specifically whether it involved one side of the body, both side of the body, how long it was there, whether there was any color change in the baby. Okay, so all these things will give you valuable information towards reaching the diagnosis of the baby. Otherwise, you will be doing all sort of investigations in each and every baby who presents with neonatal seizures. Okay. Right. So how will you prognosticate? I mean, what are all the investigations you will plan if a baby presents to you with seizures? What are all the investigations you will plan? How you will approach the baby? What are the things first you will do on the bedside as soon as the baby comes, and then how you will proceed?
First, we will look for dextrose and calcium,
Okay.
and then we'll start the management, and later we will evaluate like cranial ultrasound followed by MRI,
Hmm.
and if there is
So
sepsis is suspected.
first you complete the drug management. So you will check blood glucose, you will check calcium. If glucose is also normal, calcium is also normal, but baby is throwing seizures, what else? What next you will do?
Phenobarbital we will start.
Okay. So depending on your unit policy, whether it is phenobarbital or any other drug as first line of treatment, levetiracetam, you can start. Okay. So most of the units would use phenobarbital. I mean, you can start with phenobarbital, and if after phenobarbital, if of maximum dose, if seizures not controlled, you will go to the second anticonvulsant.
Second.
Right. Okay, so with second
Yes.
anticonvulsant also it's not controlled, then you may go with the third one as midazolam infusion or anything. Okay, so this is how you may manage the neonatal seizures. So this controlling seizure is one part. Then you will try to identify the etiology. So what are all the other investigations you will do?
So we will first consider the history and examination. So if the HIE is a suspected cause, we may not go for very extensive investigations. But if it is not HIE and baby is presenting on day 3, day 4, we will look for sepsis. We will do a cranial ultrasound and plan for neuroimaging. And we will also like to see EEG. If it is available in the unit, we may apply it bedside. Otherwise, we can do a formal EEG.
So Maria, can you enlist the list of investigations you will usually do when a child like this, baby like this, come to your unit?
So again, as a immediate management, we'll do a bedside glucose and calcium. We can do a gas with lights wherein you can quickly get in a calcium, ionized calcium, and we can also send magnesium at the same time. And as our unit policy, we usually start, we load with Ladipil. So as sir has already mentioned, we'll continue with the treatment. And in addition, we'll do the imaging, that is a cranial ultrasound, which is available bedside. And you can go for MRI. So MRI, usually we do 5 to 7 days. So So usually on the 7th day, we can proceed with MRI because otherwise we may miss the HIE changes in the MRI. Then we can do, if we are suspecting if there is history suggestive of any inborn error of metabolism. So definitely you have to do a gas wherein you can see the IEM worker where, as sir has mentioned, in acidureas there will be pH will be less, so there will be acidosis, and also the metabolic component can also be seen. And we'll go ahead with other IEM like TMS and urine GCMS we'll do if we are strongly suspecting IEM. Then so hypoglycemia, electrolyte imbalance, including magnesium, IEM workup, then imaging. And if there is refractory seizure, we usually do CFM also. That is amplitude integrated bedside EEG monitoring, conventional EEG, then MRI with MRS to see the lactate peak and the NA and peaks. And also, if nothing is conclusive, then we can go ahead with clinical exam.
So we should not forget about common things, right? CBC, CRP,
Yes,
blood
yes,
culture,
CRP,
CSF analysis. So that should come before all other lists. Okay, so this will kind of this panel would almost always identify the cause of neonatal seizures. Even after this extensive investigation, sometimes we may not be able to identify certain causes. Okay, so we may not be doing clinical exam otherwise if the seizures was well controlled. Okay, so in these two babies, seizures were difficult to control, so we went ahead with the clinical exam and identified the cause. But if seizures were controlled well, okay, and we were not able to identify any other etiology, then probably we have to give some label. Okay, so what are such labels? What are those conditions which can present with seizures but are generally considered benign in newborn? Can you name some conditions?
Startle response,
No,
hyperexplasia.
no. I'm telling seizures which you have treated, but they are benign. You don't have any other abnormality you can identify in the, even if you extensively investigate.
Sleep myoclonus.
Sleep myoclonus we won't treat. Of course, these are all differential diagnosis for seizure mimics in a newborn. Okay, jitteriness.
BFNC.
Yes, benign familial neonatal seizures and benign neonatal seizures. These two things are benign conditions which can present in a newborn. Okay, so benign. What is benign neonatal seizures? Otherwise called as
BINS.
fifth day seizures, right? Benign idiopathic neonatal seizure, otherwise called as fifth day seizures. So here again, you will not find any abnormality in the extensive investigations. If you do also, you won't find anything. So sometimes they say it has a peculiar EEG pattern only in 60% of the cases, called as theta point to alternate. So it is related to rotavirus infection, zinc deficiency in CSF, but nothing is conclusively proven. But usually these babies do really well. There will not be any family history of neonatal seizures. The other condition is benign familial neonatal seizures, wherein there will be family history of neonatal seizures, and these babies also will do relatively well, and they also can have some EEG abnormalities. Okay, if you do conventional EEG. So these babies also you have to I know they respond well to treatment, and the prognosis is normal. And some of these babies, if you do these KCNQ2 or something, may come positive. Okay, so these are all two benign entities wherein even after extensive investigation, you may not be able to identify any cause. Okay, so these babies, you just have to treat them symptomatically and reassure them and put them on follow-up. Okay, right. I think with this, we will end. If you have
Sir,
any,
I need.
yeah, please. If you have any questions, you can ask.
Sir, I want to ask regarding what is the role of amplitude integrated EEG as far as seizures are concerned, because it is said that it is not able to pick up all the seizure, like it can only pick up to 40-50% the seizure episode, and whatever seizures amplitude integrated EEG picks up, that also does not very well collaborate with clinical seizures. So what is the role of amplitude integrated EEG in the seizure management?
Yes, very good question. So definitely it is not gold standard for diagnosing neonatal seizures. Okay. So if you want to confirm neonatal seizures, you have to go for your conventional EEG. Okay. So then, I mean, AEG comes handy in identifying seizure because there may be absence of clinical seizures, but electrical seizures can be there. So how we will identify and treat them? Okay. So in identifying electrical seizures, whether your clinical seizure is correlating with electrical abnormality also, and also looking at the background pattern and presence or absence of sleep-wake cycling. So if abnormal sleep-wake cycling is there and background pattern is grossly abnormal, that means that baby is grossly encephalopathic, and it means that there could be,
So
you know,
it
some,
has a role in encephalopathy, but
sorry.
if
Yeah,
there, so
we do
it
AEG.
has a role in.
Yes, we do AEG only in babies with seizures who also have encephalopathy, not otherwise in babies who are presenting with transient seizures. Okay.
So if there are seizures on amplitude integrated EAG, which is not like identified as clinical seizures, should we treat them?
See, that is a big debate whether we should treat all electrical seizures, whether we should treat only clinical seizures. That is a big debate, and still we do not know the correct answer. Recently, also there was a study which was published in, I think, pediatrics. Treating all electrical seizures, they compared to treating only clinical seizures, but the outcome was not different. Okay. So you can choose to treat only clinical seizures also. Okay. So we still do not know the long-term outcome of such studies. Okay. So why sometimes we do treat clinical seizures also, I mean electrical seizures also, when we think that the encephalopathy is worsening. Okay. And there are no other identifiable cause for encephalopathy, and you can attribute only these repeated electrical seizures only are causing worsening of encephalopathy. Okay.
Thank you, sir.
Yeah. Any other question? Okay. If there are no questions, thank you so much. Thank you for this opportunity. Hope all of you have learned some interesting facts about neonatal seizures. Thank you. Good night.
Thank you all.